Welcome to AATCM, the Emergency Medicine channel. 80-year-old female patient came to ER with a complaint of acute onset of right-sided headache with multiple episodes of vomiting. On initial 10-second assessment, patient is conscious and oriented and obeying my commands. Primary survey, airway was patent, there is no pooling of secretion, no cervical spine tenderness. Breathing part, respiratory rate 18 per minute, saturation 96 per room air. Circulation, heart rate is 90, BP is 160 per 100 and all peripheral pulses are palpable. Disability wise, GCS is E4, V5, M6, pupils, right side is 2 mm reactive, left is 1 mm reactive. GRBS is 160.
What is the BP?
160 per 100. And exposure was, temperature was normal. Go ahead with the presentation, and on initial primary survey, patient GCS was full with symptoms of right-sided acute onset right-sided headache and vomiting with pupil, different size of pupil like NSA chorea.
Primary assessment was uneventful, isn't it? Okay, then
on sample history, there is no allergic history. Patient was known case of diabetic hypertension but not on regular medication, and last meal was taken on 4 hours back. Even 80-year-old female patient came to ER with acute onset of right-sided headache, which was radiating to right back. Patient also complaining of blurring of vision at that time and generalized tiredness, followed by patient had multiple episodes of vomiting, which was non-projectile. There is no history of double vision, no history of any exertion, no history of fever, altered sensorium, abnormal movements, no history of bowel bladder incontinence, no history of weakness, facial deviation, no history of LOC, no history of trauma, no history of vision loss. General examination, there is no pallor, icterus, clubbing signs.
So, from that history, what is the main positive points that you got? Acute onset, one-sided headache, but with no associated symptom other than
blurring
vomiting.
of vision and vomiting and generalized tiredness.
Blurring of vision is there, but not diplopia.
No diplopia, no loss of vision.
Okay. Okay, fine. Examination.
Systematic examination, CNS, conscious and oriented, pupil size 2 mm reactive on right side and left is 1 mm, and power wise all 4 limbs moving and power is 5/5. Plantar reflex is absent, and there is no neck stiffness and other system within normal limits.
Okay. So, impression.
80-year-old female patient with known case of hypertension, diabetic and CVA, acute onset of headache with blurring of vision, multiple episode of vomiting. We will move ahead with any intracranial pathology like hemorrhage.
Right. It's a first episode headache with a one-sided headache and 4 episodes of vomiting, right? Why you want to suspect intracranial pathology in this patient in whom you don't have any neurological signs? Do you have any neurological signs?
No neurological signs, but pupil asymmetry is there.
Pupil asymmetry. What can be the most common cause of pupil asymmetry for a 80-year-old female? I'm not saying that is the only condition, but what is the most common? Post-cataract surgery. That is the first and foremost question you ask is the patient status post-cataract surgery or not? If it is irregular pupils, it is most probably it's cataract surgery, isn't it? So, and you can look for ICSOL also inside. But that is the first thing to see. So, why do you want to think neurology here? Why not? Why can't it be a simple headache?
There is no history of similar episode in the past.
Okay. So, not a migraine history or any tension like headache history is not there. Fine. But that doesn't mean the patient can't have a headache now, no? Why you want to think neurology here?
Already previous history of CVA.
Previous history of CVA is there. But if previous history of CVA, what type of CVA she had earlier?
Left MCA tertiary infarct.
Infarct. So, left MCA tertiary infarct patient now presenting with a headache over
right side.
Right side. Patient doesn't have any left side of weakness, no? no slurring of speech, no angle of deviation. So, why you want think neurology? Or what are you suspecting here?
Initially, we suspect with similar vascular headache, but there is no any history of vascular headache.
Okay.
Other than we can suspect with high BP posterior.
So these are differential diagnoses.
Yes.
So those are the things you say. No, see, this patient has one episode of headache with 3 episodes of vomiting doesn't mean patient is having neurological. Patient is having headache under evaluation, isn't it? So it can be vascular headache, it can be headache, it can be headache period. 80-year-old with one-sided headache, first foremost question you should ask is any recent URTI symptoms, isn't it? Patient can have maxillary sinus or frontal sinus tenderness which is causing headache, right? That is the first and foremost question. Second thing, trauma. It's a 80-year-old patient. If they fell, hit somewhere, it can be trauma-induced headache, isn't it? The trauma-induced headaches can also has icy bleed, right? Then that can explain the vomiting episodes of the patient. So trauma history is very important here. So it can be a vascular headache, it can be trauma headache. Then as you told, due to hypertension. So if it is uncontrolled blood pressure, right now it is 160 over 100, so it's okay. But if it was more than 180, we should suspect hypertensive urgencies, isn't it? Yeah. So those are the things we primarily think. Sinusitis induced headache, infection induced headaches, isn't it? Those are the things we suspect. Then we can also keep a neurological suspicion. What are the neurological conditions that can produce this bunch of headache with the vomiting?
One is thunderclap headache is the feature of SAH, subarachnoid hemorrhage, intracranial hemorrhage, acute stroke.
What is thunderclap headache?
This is acute onset of sudden headache, which was worst experience in the life headache.
Yeah. So basically, the worst headache of the patient, if a patient says this is the worst headache that I am having, that is called as thunderclap headache. So thunderclap as such, from patient to patient, it will vary. A patient can have lower pain threshold. Patient will say even a normal headache is severe. So it's patient-centric level we have to ask. We have to ask, do you have previous episodes like this, or it's a first episode? And if it is a first episode, is it severity of the pain you should ask? But what is the most defining point of SAH? What is the most defining point of SAH headache?
Acute onset.
More than acute onset, it is maximum intensity of headache achieved within minutes. That is, within an hour, patient will say, this is the worst headache. So it is not like a progressive, slow worsening of headache. It is very acute, and very acutely patient becomes severe headache part. So that is one history we need to ask here. Duration of worsening of headache. What are the other things, other history you should ask? You have mentioned that in examination.
It's associated symptoms, multiple episode of any vomiting, headache started or during on an exertion.
Yes, so exertion, whether this headache was precipitated by acute exertion is a clue that it can be a subarachnoid hemorrhage. But not all subarachnoid hemorrhages requires exertion. Exertion just supports our diagnosis, that's all. Most of the patients with SAH aneurysmal rupture develops rupture with at rest itself. So patient may or may not give exertional history. What else?
Loss of vision, double vision.
Yeah, loss of vision, double vision, blurring of vision.
Focal neurological any weakness.
Yes. What are the most common presentation of SAH patients are? Most common presentation of SAH patients are? Loss of consciousness. Patient will transiently lose consciousness. So a history of loss of consciousness with or without seizure activity, we should be alerted towards SAH. That is, so acute worsening of headache or maximal intensity within 1 hour, and any loss of consciousness history patient is telling or bystander is telling, we should be alerted about SAH. initially itself. Otherwise, we are going to treat it like a headache with some medicines and see whether it is refractory or not. And if when refractory is when we are alerted towards SAH. Now, clinical findings of SAH. What are the clinical findings you can see in a SAH patient?
Most commonly affected by oculomotor nerve in SAH.
Not most common, but a patient can have oculomotor deficit of the affected side. But if it is a significant SAH, bilateral it will be affected. It's a false localizing sign, right? So, what will be the patient's presentation?
Ocular muscles.
Diplopia. Diplopia is patient's presentation, and patient may have ptosis on examination and pupillary asymmetry. But this thing usually happens when there is significant hemorrhage over one area or when there is aneurysm
Compression.
on the brainstem region. Towards the brainstem, when that is cerebral artery, superior cerebral artery or posterior communicating artery and all has aneurysm, you can have false localizing sign. But it's not necessary you should have third nerve palsy to say SAH. SAH presentation can vary from patient to patient according to the location of the SAH bleed and extent of SAH bleed. So, a patient is having SAH over the frontal region may have behavioral changes. SAH in parietal region can have motor deficit, temporal region can have aphasic changes, oculomotor, occipital lobe can have visual changes, or patient can have a diffuse multiple deficit if SAH extent is very high. Patient is having significant SAH, isn't it? So, presentation can vary from patient to patient. But if a patient has neurological deficit with acute headache and vomiting, you should always suspect SAH. Without neurological deficit, you can rule out other conditions before jumping for a SAH part. Okay. Now, clinical features. So, examination will also differ according to the extent of SAH and where is the location of SAH. You will have, you can have weakness, motor weakness, sensory weakness, anglomotor deviation, slurring of speech. All these things can develop if SAH is affecting those areas of the brain. If not, patient can even be normal, isn't it? Now, what is a tool that emergency physicians can use to suspect SAH in a patient who presents with a headache? Imaging is for diagnosis, right? When can you suspect, or any tool is there which can help us to suspect SAH? Like your Ottawa angle rule, you have Ottawa SAH.
Ottawa SAH rule is there.
So, Ottawa SAH rule will let you suspect SAH. So, what are the features of
rule
Ottawa?
out SAH with Ottawa SAH.
Not rule out. You cannot rule out SAH. It is a sensitivity tool. It can only let you know that there is a high probability for SAH in this patient. You cannot rule it out. Okay. So, you are suspecting. So, what are the features?
Age more than or equal to 40 years.
40 years.
Witnessed loss of consciousness.
Loss of consciousness.
Neck stiffness.
Neck stiffness.
Limited movement of the neck
Flexion.
Head thunderclap headache.
Yes. Any neurological deficit. And neck stiffness you told, no? Along with neck stiffness, any other rigidity, any other feature is there? Meningismus. What is meningismus?
Meningeal signs.
Meningeal irritation sign. So, one of the most common meningeal irritation sign is the decreased neck flexion or pain on neck flexion or neck pain as such. But patient can also have lower back pain. Lower back pain. Meningismus is usually caused by degraded RBC in CSF. So, CSF get irritated due to the degradation of RBC causing aseptic meningitis features, isn't it? But so, Ottawa SAH rule will let us know that if these features are met, we can suspect SAH in this patient. It has a very high sensitivity. It has 95-96% sensitivity. But its specificity is only 15%. So you cannot use this score to rule out SAH. Okay, but if you have a patient who is having severe headache, for example, patient has severe headache, but patient already has previous episode of migraine. Now you are given medicines, patient is not responding to it, and you are suspecting SAH, but patient doesn't have neurological features. You can use this to see whether patient has a risk for SAH, and if this scoring features is true, you should go for a CT. CT imaging to confirm it. Okay. Now this is the risk factor assessment. Now, what are the two types of SAH that you see?
Traumatic SAH and
Non-traumatic. Yeah. Traumatic and non-traumatic SAH. Non-traumatic SAH is your aneurysmal rupture SAH. Yes. Correct. So, yes. So, traumatic and non-traumatic SAH. Which non-traumatic SAH, how does the presentation come? What is the duration of presentation? Patient can present. Usually if SAH presentation, if significant, will be presenting to us within minutes to hours. But patient can have SAH up to 2 weeks. Depends on the amount of blood leaked. So, for example, there is something known as sentient headache. Sentient headache is when patient already has an aneurysm. Patient doesn't know, but patient already has an aneurysm, and there is intra-aneurysmal changes. For example, there is dissection happening in the aneurysm. Patient will have acute onset SAH like headache, but which resolves after some time. So those kind of patients has a high risk for developing aneurysmal bleed within next 1 to 2 weeks. But this is usually a retrospective finding. When this patient comes to you with eventually SAH, when you ask around whether you have any similar headache in the past, they will say in 2 weeks back or something I had similar like headache which resolved in a day, or that was either due to the aneurysm having small amount of dissection or a small bleed which is not clinically significant or self-contained bleed. Okay. Now coming to investigations, right? Yeah. How do you evaluate SAH patient?
In this patient, we first of all move forward with neuroimage like CT brain plane.
Okay. CT brain plane you will take.
Within 1 to 6 hours, CT can pick up the bleed.
Yes.
In this patient, CT finding is significant SAH in the supracellular cisterns with extension into the third and fourth ventricle.
Okay. So within 6 hours of any aneurysmal rupture, CT has a very high sensitivity and specificity to identify aneurysmal bleed as such. Now, once you take CT, there can be patients in which CT is normal, isn't it? And there can be patients in which CT is positive. CT positive is clean. But if CT is negative, how will you make sure patient doesn't have SAH?
CT negative, we will move forward with symptomatic is there, then we can move forward with the LP, lumbar puncture.
Yes. So, CT negative always doesn't mean patient doesn't have SAH. CT negative patient can develop SAH with a minimal bleed.
Anemia patients.
Yes.
Or the radiologist is not okay with.
Yes, operator bias or poor quality CT scans
or after more
thicker,
than 1 week, it
yes,
lysis of the RBC results, then CT not negative.
Yes. So in those kind of patients, but meningitis signs will be, meningismus will be present. So if patient is not responding to our analgesic treatment, even though CT is normal, we should go ahead for a lumbar puncture. So lumbar puncture will rule out SAH. What are the features of SAH in lumbar puncture?
Lumbar puncture, first of all, open up high pressure.
Yes, increased high pressure, but that is only during acute phase of SAH. Like 1 week after and all, there won't be elevated SAH, opening pressure. But in acute phase, elevated opening pressure. Then
Xanthochromia.
xanthochromia. How do you say xanthochromia? What do you look for?
Degradation. It is a degradation.
What do you see?
It is a yellow color thing. We can keep other normal 2 tubes take and compare with the normal tube.
What normal?
Uh,
What is in the normal tube? When you tap and get the spinal fluid, the spinal fluid may have a yellowish tinge or a pinkish tinge. That is xanthochromia. So pinkish tinge means there is active blood. That is what gives it the pinkish tint, or yellowish tinge means already degraded RBCs. That is xanthochromia. Okay. Xanthochromia is yellowish tinge and the pinkish one means acute bleed. But the problem is what? The problem is you do not know whether your LP is traumatic lumbar puncture or whether it's active bleeding.
That we can get with if traumatic, the number of the RBCs will be decreases within multiple tubes. So
Yeah,
if it is not decreasing with multiple tubes, we can.
Yeah, so you take CSF in multiple containers, multiple small narrow tubes, and if the amount of RBCs is coming down in each tube, you can say it is a traumatic puncture, and if a RBC number is not decreasing in each tube, you can say that is a SAH. But in clinical practice, we rarely get to do this, isn't it? But what are the other investigations we do?
Imaging.
No, in LP.
Other investigation.
Total cells, which includes total RBCs, and hemoglobin residue is what we check for. So RBC counts, hemoglobin residue, and total counts is what we check. So LP and CT is the two investigations you do to diagnose. So you diagnosed what? SAH. For example, this patient CT is proven, right? Significant subarachnoid hemorrhage involving
basilar artery. The suprasellar cistern with extension into third and fourth
ventricle. Okay. So you have diagnosed SAH. Now what is your next step?
Again, we will reassess the patient.
No, your next step is not reassessment. That is after treatment, then only you reassess. Your next step is what? Gradation of the extent of SAH. How much SAH is there, or what is the patient condition going to be with this level of SAH, isn't it? So what are the scoring systems you use for SAH?
Hess and Hunt scoring system.
Hess and Hunt is the most common. Most famous is Hess and Hunt system. Do you know Hess and Hunt system?
There is 5 grades. Grade 1 is mildly asymptomatic, mild neck rigidity or no focal neural deficit, no headache. Grade 2 is mild headache, mild neck stiffness, no focal neural deficit. Grade 3 is focal neural deficit is present.
Mild headache, mild neck stiffness with
focal neural
deficit.
Grade 4 is patient becomes drowsy with one side hemiparesis. Grade 5 is
not one side, neurological deficit present.
Grade 5 is patient becomes coma.
Stupress patient and with the neurological deficit. This is Hunt and Hess. There is another one now. World Neurosurgeons, World Federation of Neurosurgeons.
Grade with including with GCS score and motor deficit. Grade 1 is GCS is 15, motor deficit is absent. Grade 2 is 13 to 14 GCS
without motor deficit.
Grade 3 is 13 to 14 with motor deficit.
With the motor deficit.
Grade 4 is 7 to 12 with present or absent motor deficit. Grade 5 is 3 to 6.
With or without. Because obviously when GCS is 7 to 12 and 3 to 6, there will be motor deficit. That is why our GCS fell. But both of these are easy to grade the SAH. Higher the grade, worse the patient's prognosis is. This is why we should
this grade also severity. We can use Terson syndrome. Like with this grade, we can use pre-retinal hemorrhages.
Yes.
That also prognostic mortality is
very high. But pre-retinal hemorrhages, we need to look into the eye. We need an ophthalmoscope to check. But if we find it, it shows that patient is in a very bad SAH. Patient's prognosis is very bad. Okay. Now we have graded the severity. So what is the next step?
Management.
Yeah, management. What are the types of management which is there for this patient?
Initially, first of all, we will head and elevate the patient for 30 to 20 degree.
Yeah, so we have medical management, that is supportive, and definitive management, which is surgical. Okay, so simultaneously we can manage the patient, but we need a neurosurgical consultation for emergency clipping or endovascular coiling of the SAH, because without doing that, the patient will always bleed. So our supportive treatment is to prevent secondary brain injury, but already involved brain injury or any re-bleed cannot be managed with our medical management. So we need an emergency surgical management for endovascular coiling or clipping of aneurysm. That is first thing. Second is our management. So from our management, how will you go? First is head and elevation, as you told.
Avoid the necklines.
Correct. Because
it increases the intracranial pressure.
Yeah, it decreases the outflow of venous outflow, thus increasing ICP. Then
if look for any desaturation.
Yeah, so before desaturation, what is important? We are emergency physicians. Airway breathing, right? So airway is
if there is this patient GCS is full. If there is any loss, indication for into airway management is
GCS
drop less than 8.
GCS less than 8 is there. We should prophylactically intubate the patient.
Otherwise, if we need more sedation, more analgesia.
Yeah, patient with SAH can have significant agitation due to pain or meningeal irritation. So such patient may require sedation. So heavy sedation you are giving, or patient is having severe hypoxia, hemodynamic instability, or GCS less than 8, you should intubate the patient. And then your ventilation comes, right? So ventilation is?
Maintain the saturation more than 94. Then
prevent hypoxia. Brain is already having ischemia, isn't it? So if you give hypoxia also, brain cells will be much more dead. Okay, so prevent hypoxia.
Then circulation part, control the BP less than 160 or MAP less than 110.
Okay.
It is because it is central perfusion pressure is equal to MAP minus ICP. So
cerebral perfusion pressure
is equal to MAP.
CPP is
MAP minus ICP.
Mean arterial pressure minus ICP. But what is ICP?
Intracranial pressure.
No. How do you know ICP? You don't know ICP. So how much will you decrease?
ICP is MAP,
cerebral perfusion pressure is mean arterial pressure minus ICP. But unless you have placed a intrathecal or a intraventricular device, you don't know ICP value. So how much will you decrease MAP?
MAP to maintain less than 110.
So it depends on the patient. If this patient you have 160 over 100 BP, right? In this patient, any BP less than 160 over 110 is okay for us, because MAP will be less than 110. Why? Because we know patient is fully conscious oriented. But think this patient is having GCS of 8 or 5. Patient is stuporous or patient is drowsy. Now the question is the patient drowsy due to SAH, or is the patient drowsy because of SAH causing decreased ICP, increased ICP?
Decreased perfusion.
Decreased perfusion. Because ICP increases, the difference between mean arterial pressure and ICP comes low. That means cerebral perfusion pressure comes low. The body will increase blood pressure to maintain cerebral perfusion pressure. So in a altered mental state patient or an unresponsive patient, if you decrease BP rapidly, patient will go into ischemia. So in a SH, patient is having full GCS, fully conscious, oriented, obeying to you, you can slowly decrease BP to either achieve a systolic BP less than 160 or a mean arterial pressure less than 110. But in a altered mental status or a drowsy patient, you should be very careful decreasing BP. Okay, now you want to decrease BP. Think that her BP is 200 over 120. You want to decrease BP. What are the drugs that you give?
Ideally, we will use injection labetalol.
Okay. Intravenous, what you have is injection labetalol. Any other drug is there? Much more better drug?
Labetalol, nicardipine.
Nicardipine very rarely you will get in India, I feel. I don't think it's very common in India. Nimodipine you can give, but IV nimodipine should never be used. IV nimodipine can cause significant hypotension. So, IV nimodipine we are not using. We will come to nimodipine. Any IV drugs?
NTG, but it is
No,
not.
not NTG is not IV drug as such. What is aneurysm? Where is aneurysm? Aneurysm is in a
arterial.
artery.
Hydrolysis.
So you can give arterial vasodilator, isn't it? Which is hydrolysin. Injection hydrolysin is available. So you can give injection levetolo or better injection hydrolysin. These two drugs you can clearly give to the patient. And what about vasodilators like venous and arterial vasodilators, like what you were telling, NTG, sodium nitroprusside.
N3G maximum to avoid NTG
Why?
Because it vasodilation causes increase the cerebral blood flow.
It not only causes vasodilation, it increases cerebral blood flow, causing
Rebleeding.
Chances of increased rebleed. So in SAH, nitroglycerins should be avoided as much as possible, and arterial vasodilators should be preferred. Okay, so that is BP control. Then what is other management things? Airway, breathing, circulation.
Prevent hypovolemia.
One more thing. So in circulation itself, BP control we told, antihypertensive. What is the drug of choice for any aneurysmal, any SAH? Non-traumatic or traumatic SAH, what is the drug of choice which will cause intracranial vasodilation? That is the only drug which has shown to improve patients' mortality and morbidity. Even though mechanism is doubtful, that is the only drug which has clearly shown to improve patients' condition. Nimodipine. Nimodipine is the drug for subarachnoid hemorrhages. Dosage is
40 mg, 60 mg Q 4th hourly.
Yeah, 60 mg. 60 mg every 6 hours you should give. That is 4 times in a day you should give. So when a patient presents to you with a lower blood pressure, like 160 over 100 or 170 over 100, before giving arterial vasodilators or labetalol, you should start nimodipine first, because nimodipine itself will control blood pressure inside the intracranial level, and that's a drug which is proven to improve patient condition. So you should not decrease BP first, which will prevent nimodipine administration. So nimodipine is given orally or through rice tube, never IV. Okay, so nimodipine comes under blood pressure management, but it is a drug of choice for any aneurysm, any SAH, subarachnoid hemorrhage. Okay, then
we prevent hypovolemia. We will manage euvolemia.
Basically, should not give extra fluid to the patient and prevent hypovolemia. Hypovolemia means decreased blood volume, causing decreased cerebral perfusion pressure. Increased blood volume causes? Increased blood volume causes decrease in osmolality, causing increased ICP due to edema. Low serum osmolality means increased redistribution of the thing from intra-arterial space to extra vascular space, causing edema increase, causing rise in ICP. So hypervolemia should be prevented and hypovolemia should be prevented. Maintain euvolemia. Preferably give physiological fluids more than DNS and all. Physiological fluid like renal lactate or cabilite and all can be used. Okay.
Then we can start with anti-seizure prophylaxis.
Over. 2 more things, minimum.
Circulation.
Secondary brain injury. We don't want brain to work more.
PO2 more than 90.
That is after.
PO2 more than 90, PCO2 35.
So PO2 he told. So PCO2 in a intubated patient only we need to control. Basically you need to maintain normal PCO2 level. You don't want to increase PCO2, which will cause cerebral vasoconstriction. Decrease PCO2 will be advantageous if the patient is having
Low
severely raised ICP or patient is in coning. Otherwise,
Drop in GC.
PCO2 means washout should not be done. Okay, so that is PCO2. Anything else?
Glucose control.
Glucose
Prevent
control.
hypoglycemia.
Yeah, euglycemia should be maintained. Patient should never go into hypoglycemia. Hypoglycemia as such doesn't affect the brain, means in the short term. The long term definitely, but not in the short term. So hypoglycemia should definitely be prevented. Then one more. Hyperthermia. Fever should be treated. So fever means increased oxygen demand means again ischemia. So hyperthermia should be prevented. This is secondary brain injury. Okay, now this is the medical management for the supporting care that we give. Now, what about SAH management? There is raised ICP features. No, what are you how are you managing that?
Can anti-edema measures like
What are the anti-edema measures?
3% NaCl we can start with.
Okay, hypertonic fluids you can start. 3% NaCl is the most common thing that you get.
If there is coning or
How much will you give?
if more than the upper limit of the normal, it's more than 145.
Yeah, so you keep serum sodium level between 145 and 155. So basically serum osmolality should be more than 310. That is what you aim to achieve. Okay, more than 295. More than 295 you should maintain. Okay, so hypertonic saline you can give. What about this patient having SAH with a significant stupor, pupillary asymmetry, or patient is having very rapid varying breath?
You can start with mannitol.
Mannitol. So when there are features of coning, you should give mannitol. But mannitol is not a treatment, continuous treatment for a patient. So if you are going to give mannitol, patient should be planned for craniotomy. For relieving of ICP pressure, craniotomy should be planned. Okay, so that is anti-edema measures. What about seizure? You were talking about seizure now earlier.
Seizure prophylaxis we can start.
Do you have to start?
There is two thoughts of is there. Better to start with seizure prophylaxis. But avoid phenytoin like drugs.
Yeah, so basically seizure prophylaxis is not routinely needed unless you are dealing with a extensive SAH. Extensive SAH predisposes the patient for seizure. So you can start anti-seizure medication. Even if you don't start for simple SAHs, it's fine. And development of seizure shows that patient is worsening. So suppression of seizure activity is not going to improve patient condition. It just tells us that two schools of thought that you told is, one school of thought is if you suppress seizure, you will never know whether patient is worsening or not. And the other school is like, if patient develops seizure, seizure is uncontrolled brain activity.
Bleeding.
That means more resource dependent. That means more ischemia and brain cell death.
Also
So these are the two
bleeding.
school of thoughts. So in some consultants prefer giving anti-seizure medication to the patient to prevent secondary brain injury, while some consultants say that unless it is a significant bleed, don't give anti-seizure medicines because we need to observe the patient to analyze whether patient is worsening. Most of the anti-seizure medicines can also develop suppression of sensorium. So patient sensorium may not be improving. So neurosurgeons may find it difficult to assess patient's response to treatment. Okay. So medical management. Anything else?
To and look after any hyponatremia or any electrolyte imbalance.
So we told we should start hypernatremic solution, right? So hyponatremia is out of question.
Then DVT prophylaxis.
DVT prophylaxis. You have to understand this patient is not going to get out of the bed for next couple of days. So DVT prophylaxis can be started from ER itself. There is no point in waiting for critical care. We can start DVT prophylaxis. So when you give DVT prophylaxis for this patient, what will you do? Stockings and heparin
devices. Heparin.
So what about anticoagulation, antithrombotics, Anticoagulation, antithrombotics, thrombolytics and antiplatelets in SAH.
Patient was on anticoagulants and antithrombotics, we would stop that drugs.
Yes, you should completely stop the drug and
And if there is anticoagulants, reversal.
reverse the
reversals
drug.
are-
So patient is on anticoagulants or thrombotic agents, it should be stopped and complete reversal should be done. That means if warfarin based products are being used, you should give
injection vitamin K and
injection vitamin K and
platelet complex concentrate PCC,
what is PCC?
prothrombin complex concentrate.
Prothrombin complex concentrate should be given. Prothrombin concentrate, complex concentrate is not very readily available. We have, but not very readily available. What will you give?
Injection
FFP. So 80 ml per kg of FFP should be transfused. So immediate reversal of anticoagulation and stoppage of drugs. What about antiplatelets?
Stoppage of the antiplatelets.
Correct. Stop antiplatelets and
If patient on
usually we don't do it, but what is the guideline telling? Platelet transfusion. If patient is on anti-platelets or if patient is having thrombocytopenia less than 1 lakh, patient should be given platelet transfusion is what the guideline is telling. But most of the hospitals do not do that. Thrombocytopenia usually they transfuse platelet, but antiplatelets, because of antiplatelets they don't usually transfuse platelet transfusion, but guideline is telling us to transfuse platelets. Okay, so what about antithrombolytics? What is an antithrombolytic agent? Tranexamic acid. Yeah, antifibrinolytic activity. No. So what about tranexamic
we
acid?
can give, but there is no other very useful to.
There is no mortality benefit or morbidity benefit, so you don't have to give. Even if you give, it is not going to affect the patient as such. What is the most common complication of tranexamic acid? Hypotension. Tranexamic acid itself can cause hypotension if given bolus. That is why tranexamic acid is given in 100 ml NS IV over 30 minutes. So bolus tranexamic acid can cause hypotension. So in SAH, if you think the patient's blood pressure and all is on the lower level, try to avoid tranexamic acid because it is not going to improve the patient condition. Okay. What else?
Pain control.
Very good. Very much important. Analgesic. Most of the patients are irritable due to pain and meningeal irritation. So anxiolytics and pain control is very much important here. What are the drugs you will give?
Start with low drugs like paracetamol, then go to opioids.
Yeah, you can always give opioids. You should not be reluctant in giving opioids for SAH patient. You can give opioids, long-acting opioids as IM dose you can give, and intermittently you can support it with lower analgesics like paracetamol or NSAIDs. But opioids should be given. There is no point in making the patient having more pain and rising ICPs. Anything else? This is it, right? Yeah.
Nimodipine, we will.
One more thing, constipation is there, but that is more of a critical care topic rather than constipation prevention features and all are there, but that is critical care. Anything else?